And therefore, at this time, I would like to introduce Dr. Christine Rabinak, who will be our first speaker. Dr. Rabinak is an assistant professor in pharmacy practice and the director of the Translational Neuropsychopharmacology Laboratory at Wayne State University. For the past 11 years, she has focused on 3 complementary lines of research. 1, affective neuroscience. 2, cognition, emotion, interactions. And 3, integration of multimodal approaches to assess emotional learning and regulation, including human models, rodent models, clinical populations, functional MRI, psychophysiology, electrophysiology, pharmacology, clinical assessments, subjective responses, and behavior. That's a pretty full plate. Over this period, Dr. Rabinak has established an internationally recognized, productive, comprehensive, and continuously funded research program in translational neuroscience as PI or co-I of multiple grants. She is the past recipient of an NIH KL1 Career Development Award and is current principal investigator of a $3.8 million NIH grant on exploratory clinical trials of novel interventions for mental disorders to test a novel cannabinoid chemotherapy that targets fear extinction neural circuitry for improving outcomes for adults with post-traumatic stress disorder. Without further ado, Dr. Rabinak.
Thank you, Dr. Commissaris. So I'm going to give you a brief overview of pharmacology, toxicology related to marijuana, and then a brief history of kind of where marijuana has been in the legalization within the United States. So what's marijuana? You probably know it by a variety of different names: weed, herb, pot, grass, ganja, Mary Jane. It's basically going to be this greenish gray mixture from the dried shredded leaves and flowers of the cannabis sativa plant. There's also other strains known as cannabis indica. Primarily from the cannabis plant, there's 3 kind of traditionally better known cannabinoids. There's over 400 different types of chemical compounds found in the plant, but the 3 primary are cannabinol, cannabidiol, and delta-9 tetrahydrocannabinol, or THC, which is probably the one most of you are familiar with. THC is the only one with significant psychoactive properties. CBD, actually, the cannabidiol, is actually thought to have no psychoactive properties, but can block those of THC. So it can block those effects. It can also have anxiety reducing effects. So what does marijuana do? Well, there's a variety of different things, and it kind of depends on what is going to happen based on the individual. So generally, depending on your route of administration, effects can be felt within 15 minutes of administration. Peak effects can occur within 30 to 60 minutes post-smoking and last 2 to 3 hours, depending, like I said, upon the route of administration. Oral has a slower onset and a longer duration, so things like edibles, for instance. Cannabinoids are highly lipophilic, so that means that when you ingest cannabis, be it smoking or eating or anything, some of those chemical compounds are going to be uptake in the fat in your body and then slowly secreted out again. And so that's why you can test positive weeks after taking, smoking a joint or eating a brownie or whatnot. So it has this kind of longer life within the system that can be detected weeks out, even after the intoxicating effects are gone. So, like I said, it has a variety of different effects. So ones that we might hear of most are people being happy, having the munchies, feeling, low anxiety. But it can also have another effect. And typically at higher doses of THC or more cannabis, you can start seeing things like paranoia, anxiety, kind of these negative side effects. So THC in particular has this bidirectional effect on the system and on the way the person experiences their high. And why is this the case? Because it acts on receptors in your brain that are important for controlling your emotions, controlling feeding, controlling your time perception, your balance, and so forth. They're located all over the brain. And so when you ingest it or you smoke it or whatever, it's going to activate all these different receptors. And one dose for me might have a very negative effect, and that same dose in Dr. Kamasaris might have a very positive effect. And that can be based on our fat concentrations, brain makeup, and so forth. So it's very, there's a lot of individual variability. So I already said it acts by working on receptors in your brain, and there's specific receptors in your brain known as cannabinoid receptors. They're also located in your periphery. And the receptors in the periphery are thought to be really responsible for immune response. And so when we think about things like using marijuana or THC for pain-related disorders or chemotherapy, for instance, that's acting in your periphery. So we have naturally occurring chemicals in our body that mimic or look like THC, and these are called endocannabinoids. So normally we have a system in our body that is designed to create these, act, and be released, and produce these different types of effects independent of consuming marijuana. Toxicity with marijuana, unlike most other drugs, it's extremely low toxicity. Okay, there's been no reported fatal overdoses with cannabis use. In fact, this here, so the ratio of cannabis required to produce a fatal overdose to the amount required to saturate CB1 receptors and cause intoxication is about 40,000 to 1. Okay, so that's really different than other types of drugs of abuse, for instance. The history is pretty interesting, and so I created this timeline here kind of summarizing some of the major events. So the first recorded kind of records of cannabis, sativa, and marijuana dates back at about 500 BC, primarily in Asia, and was used primarily for different medicinal reasons. And so it really had this medicinal purpose used for kind of to treat everything. And then in 1794, we come to the United States. There's evidence in a letter from George Washington to his farm manager to plant hemp everywhere. And so in fact, at that time, farmers in the United States were required to grow hemp plants. And so a hemp plant is the same as a cannabis plant. It just has a lower concentration of THC. So if you allow that plant to produce more THC, it now becomes the cannabis, sativa, marijuana plant. Same plant, okay? So every farmer was required to do this, and they were fined if they didn't. And in 1797, the USS Constitution was built with 50 tons of hemp rigging and used hemp sails. In 1800s, cannabis use in over-the-counter tinctures were commonplace in American pharmacies. Pretty much any kind of medication that you found in a pharmacy contains some sort of cannabis product. And then in 1906, the Pure Food and Drug Act required drug labels to list dangerous drugs, and now cannabis started to get a negative rap, okay? And whether it was well-deserved or not. So cannabis was included in that. So that's where we start to see this kind of, well, maybe we're gonna get a little skeptical about using it. In the 1920s, the Mexican Revolution brought recreational marijuana use to the United States. And it's around this time and with prohibition and everything where the use of marijuana recreationally started getting a lot of negative press and was kind of linked to, oh, it's these immigrants coming in and trying to get people high and make them do bad things. And so there's a lot of racial undertones associated with this that were really had nothing to do with whether or not marijuana was having these negative effects or not. 1930s, you can see a lot of anti-marijuana propaganda spread to produce fear among the public. In 1937, the Marijuana Tax Act was the first federal U.S. law to criminalize marijuana nationwide. And in the 1940s, though, when we had World War II, the U.S. government actually said, okay, hold on, we're going to allow hemp growing again for farmers to help produce, hemp for the war purposes. So there was an exception made for a brief period of time. And then in the 1950s, there were stricter sentencing laws for marijuana possession. So people with a first offense could spend up to 2 to 10 years in prison. In 1960s, kind of like hippie love time, and it's coming back to be positive. In the 1970s with Woodstock and everything. In between those times, people started using it more recreationally again. You started seeing this primarily in the white upper middle class. In the 1970s, the Controlled Substance Act was signed into law by President Nixon, and this repealed the Marijuana Tax Act. And for the first time, this is when marijuana was listed as a Schedule I drug. And so then kind of continuing with this war on drugs, in 1989, President George Bush kind of declared a new war on drugs. And so again, kind of with this negative case, not just for marijuana, but other drugs as well. 1996 is where we start seeing a turn again, back into kind of like maybe it's not so bad and people starting to push for reconsideration of marijuana in a medical sense. So 1996 is when we have the Proposition 215 passes. California is the first state to legalize medical marijuana. 1998, medical marijuana was legalized in Alaska, Washington, and Oregon. 2012, you probably remember, Colorado and Washington passed their initiatives and amendments. And then as of January of 2018, nine states and Washington, D.C. have legalized marijuana for recreational use. So you can see it's kind of had this kind of wave happening where it was widely accepted and not illegal. And then it became illegal and was part of around this prohibition period. And then now it's starting to kind of have this upshoot and a wave. And one of the key things I want you to think about here is that one thing that has really not changed is our ability to be able to do research on the cannabis plant. So regardless of if it is good or bad or effective or not, we can't really study that with our current regulations, the Controlled Substance Act of 1970, and then some of the regulations the DEA has on research of the cannabis plant. So with all of this legalization, we have people that are taking this drug in a medical, let's say, setting without any prescribing information, dosing information, without any evidence to back whether or not it's effective. And for me as a researcher, that seems very irresponsible of us as a public. And we're doing a disservice to patients. So until we need to be able to change some of these laws in order to allow us to do the research to determine what is effective, what isn't, what are the long-term consequences. There are some drugs that are coming into FDA approval. So one that has been FDA approved for a while is a synthetic THC, so it's not based on the plant, but it's dronabinol and that's Marinol, primarily used to treat nausea in cancer patients and stimulate appetite in AIDS patients. Sativex has been legal mainly in Europe and Canada for seizure disorders, and that's a mixture of THC, CBD. And most recently, you probably heard that Epidiolex is a cannabidiol-based drug that was just recently FDA approved for seizure disorders in children. So there is some change, and we're pushing forward, but there's a lot of stuff we don't know. So I want you to keep that in mind as you think about these proposals and so forth.